This presentation is adapted from Pulmonary, Sleep, Cardiology, and Critical Care Academy, an online CME-accredited course for advanced practitioners and physicians. So let's get started with some basic definitions. In distinction to hypertension emergency, hypertension urgency is always asymptomatic by definition. It's defined by a marked elevation of blood pressure, typically greater than 180 over 110. The management of hypertension needs to be played out over hours to days and can be managed orally. No ICU admission is required usually, unless there are other comorbidities requiring ICU admission. In contrast, hypertension emergency is defined by symptoms or end organ damage. Because of that, there is no exact blood pressure criteria. If we see end organ damage or symptoms related to an elevated blood pressure, it's a hypertension emergency. As an emergency, this needs to be addressed more rapidly within minutes to hours and usually requires intravenous medications. Signs and symptoms include mental status changes, neurologic changes such as headaches or focal neurologic findings, chest pain, or dyspnea. And we can see end organ involvement. In this example, we see an aortic dissection noted by the flap in the ascending aorta shown at the arrow here. There's also an expanding aneurysm as the ascending aorta is very large relative to the descending aorta. Acute coronary syndrome and acute pulmonary edema. In this x-ray, the patient's in heart failure with vascular congestion shown well in the circled area and the blunting of the costophrenic angle shown at the arrow. Accelerated renal failure with malignant nephrosclerosis. These are sclerotic nephrons that have dropped out. CVA or intracranial hemorrhage or encephalopathy, including seizures and progression to coma as neurologic complications. And here we see dense blood within the ventricles. So this is an intraventricular hemorrhage. Papilledema. So here's the disc is completely edematous in here. And microangiopathic hemolytic anemia. There's a very low platelet count. We only see a couple of these little tiny platelets, and we see these fragmented red cells, which is right over here. This is destructive changes during severe hypertension in the microvasculature where red cells are actually lysed and broken apart into fragments. These fragments are called schistocytes. For patients who are accustomed to being severely hypertensive, overzealous or even too rapid correction of hypertension can lead to organ ischemia. This is due to a normal physiologic mechanism known as autoregulation. Autoregulation is a vascular process where there is an adjustment of precapillary arterial tone to regulate inflow of blood to the organs in order to maintain a relatively constant flow to that organ over a fairly wide range of mean arterial pressures. This process protects our end organs from excessive blood flow or inadequate blood flow. Using the brain as an example, excessive cerebral perfusion is a risk for hemorrhagic stroke, and inadequate blood flow is a risk for non-hemorrhagic stroke. Let's turn our attention now to end organ autoregulation curves. On this graph, we see end organ perfusion on the y-axis as a function of mean arterial pressure on the x-axis. We can see that the end organ perfusion is well maintained over a wide range of pressures. In this example, from a map of 60 to about 110, there's no change of end organ perfusion. And what's happening here is rather than more end organ perfusion as the blood pressure goes up, which would not be healthy, the body is regulating the blood flow to the end organs by closing the precapillary arterioles down to put a clamp on how much blood gets into the organs. That keeps the flow relatively constant over a wide range. So I'm going to mark this area as green to say that this is a healthy zone for this patient. This patient loves to have a map between 60 and 110. Their end organs are happy. Now, in a healthy person that gets hypertensive, we start to get into trouble as the pressure goes outside the range. We're not saying something bad is going to happen. We're just concerned. The map is 120. They may be fine, but they may also start to have complications. And their map here goes under 60, from 60 down to 45. They may be okay, or they might start to have oliguria or lethargy. So we're going to mark these zones as the yellow zones of concern when you're outside the range. Now, as you're further outside the range, we're extremely concerned, and you'll either get an organ dysfunction. If you have no symptoms, this would be a hypertensive urgency, or if you have symptoms, you're clearly in hypertensive emergency here. Actually, if you have symptoms, you're even in hypertensive emergency here. Any hypertensive reading with end organ involvement is a hypertensive emergency. So these areas where you're well out of the autoregulation range are very concerning. I mark them in red. Now, someone who's chronically hypertensive has what we term a shift of the autoregulation curve to the right, which I've drawn in purple. They still autoregulate, but they autoregulate around the higher blood pressure. Here, they prefer keeping their pressure from about 85 to about 145. That's their normal range for a chronically hypertensive patient. So what that means is they shift their happy spot, the green spot, to the right over here. So they're now auto-regulating around this pressure. So they actually tolerate higher pressures, and that's why you'll see a chronic hypertensive patient with renal failure come in with a pressure of 200 over 100 and be smiling. They're not even having symptoms. They're used to it. So they can tolerate higher pressures. That's not to say that they can't have a hypertension urgency or emergency, but they tend to tolerate high pressures better. The problem with chronic hypertensives that have a shift of the curve to the right is on the low end. And as you can see, a map of 80 or 70, which would be fine for a normal person, is absolutely a relative hypotensive reading for these patients. And this is the reason why we don't want to just normalize the blood pressure to a map of 70 in the beginning. So we try to be slow in the correction of most patients with severe hypertension emergency and not try to normalize all the way in case they're on the right part of this autoregulation curve. So for that reason, we'll decrease the mean arterial pressure by about only 25% within 60 minutes, not to normal. And then we'll still target either low hypertensive, let's say 140 over 90, or high normal 130 over 85 within 6 hours, but we certainly don't want to have a perfectly normal blood pressure within 6 hours. We can then slowly normalize the blood pressure over several days, and this allows this autoregulation curve to slowly move back towards here. The body will readapt and start to regulate the blood pressure around the more reasonable target range. If you'd like to learn more, please visit our educational center at pulmonaryandsleepacademy.com, where we have 70 hours of self-paced online CME-accredited courses covering pulmonary, sleep, cardiology, and critical care medicine. Please enjoy more of our short visits on our PSA YouTube channel. You can purchase our full courses with an exclusive 10% discount code using YouTube10.